Everyone ready? Yes, fantastic. And the only thing keeping you from your Friday afternoon, I told you it was going to be a 4-hour session, right? Don't tempt me. I may do. You guys would probably stage a walkout if I tried to pull that, right? You see it happen. Anywho, any questions from the last time we talked? Anything at all? No? Okay, let's continue on. So we kind of got the fundamentals, kind of like why we even care about epidemiology in the first place. Now we get into more of the nitty gritty here. We're going to look at data sources and types of measurements we're going to be dealing with. And so again, some of you were questioning, like, well, how do I even study for this stuff? This is the kind of stuff we're going to start to need to know, right? In terms of what kind of data we're looking at, where we're getting data from, and how we actually do these measurements. So let you check out the objectives there. I want to get into. So we kind of briefly touched upon this last time. We're talking about sources of health data. What are some sources we mentioned? Do recall there was like a 2-hour period we were talking about this stuff. And most of you might have entered a fugue state during that period. I think the lights were off then too, so that was probably working against us. But really, departments of health can be a big source for a lot of information, right? We can look at things like the U.S. Census can be useful bits of information, third-party payers. There's a lot of places we can get information from, because getting data yourself, hard or easy? It's difficult, right? It's time consuming, it costs money, and so if you can pull information from already collected data, that's always going to be easier. When we're talking about denominator data, when we're looking at epidemiology, what are we talking about? Generally going to be the population at risk, right? The population we're actually interested in. If we're looking at people who live in Florida, people who live in the United States, people with hypertension, whatever, that's going to be our denominator there. And so things like census statistics can really help us out with that, right? If we're looking at people who live in inner cities or people who live in rural communities, right? We can use information like that to help us out. The numerator are going to be the events, the people who have the events who are actually developing the conditions that we're concerned about, right? It's always going to be our numerators, the number of people who develop or have the condition that we're interested in. And so we're going to see that a lot of places will go ahead and collect data, usually every 10 years or so. And in fact, do we have a census coming up pretty soon? We do in 2020, absolutely. Every 10 years, the U.S. does their census. Why do we care about the census? Gives you an idea what the population looks like, where the population is. I mean, is the census like, does it really matter if you do it or not? Yes, it absolutely matters. 100% absolutely should participate in the census. Now, if you're still a dependent on your parents, then you don't have to do it, obviously. But if you're an independent person, as some of you might be, yeah, you should absolutely participate in the census, because things like funding for programs will be determined based on where the people are, right? How about district maps for things like, state representatives or federal representatives? Based on the census data, right? A lot of information comes from that, so that's why it's really important that we participate in those sorts of things. Anyway, but other things that can help us out with this information are going to be things like vital statistics registration system. So for instance, every time someone is born, that gets reported out. Every time someone dies, that gets reported out. And so all that information can really help us out in terms of determining when are people entering life and when are people leaving it, for instance. Now, when you're looking at things like cause of death, is that something that can be kind of ambiguous, or is it always like really well known why someone died? Sometimes it can be ambiguous, right? Sometimes things might get misdiagnosed. Someone just drops dead all of a sudden. If they don't do a proper autopsy, then who knows what happened, right? You guys familiar with like the difference between a medical examiner and a coroner? What's the difference? Yeah, so a medical examiner is a physician. They are especially trained in pathology. They have a lot of education, a lot of skill. Coroners, on the other hand, are usually like elected officials, and they may actually have no medical background whatsoever, right? So depending on where you live, you may find that you have medical examiners, you may have coroners that are identifying the cause for death. And if you were to die, would you rather a medical examiner determine your cause or someone who had no medical background? Probably the medical examiner, right? They probably have a better idea of being able to diagnose that sort of thing. So for instance, in Florida, you know what we have? We only have medical examiners. You guys ever heard like Dr. G? And that was actually in Orange County, right? So this is actually, actually before it used to be hard to get like students in to go do a tour of the medical examiner's office, but now sometimes we can get people in, and so it's really fascinating to see their process and how they go through and determining the causes of death and things like that, and the chemical analyses and whatnot that they do. But it's really important that we get a good, accurate sense for why people are dying, because that can give us an idea of the kind of trends of things that are happening, whether infectious or otherwise, right? Because again, what's like a really big cause of death we're really interested in nowadays, especially in Florida, kind of an epidemic sort of level? Opioids, right? So if we have people that can correctly identify opioid overdose deaths as opposed to anything else, that can be really useful to determining what's really going on. So as I mentioned, census is undertaken by the government every single year, and so typically around April 1st. So 2020, it's going to be happening again. And so this is really important because it helps us with like projections of data, gives again an idea of like where to fund certain things based on populations and whatnot. Is anyone familiar with any controversies with the census as of late?
Are they asking if they're illegal immigrants on the census?
Yeah, so are you a legal U.S. citizen or not, right? Why was that a controversy? The answer should be easy.
They don't know whether to report it because they might get tracked, or like they might be counting people who aren't citizens and stuff like that.
Right, so if people are worried about ICE coming and knocking down their door because they're not a citizen, because they answered the census, what do you think it's going to do to reporting? You start to underreport, right? And so that means that maybe we start to undercount the number of people that are actually here, or the types of people that we have that are here. And so again, you'll find that these kind of controversies may come up from time to time, but it's just interesting to just kind of keep your kind of ears out for that sort of thing, because again, it may be affecting how funding is going to go, how different things are going to be counted, so to speak. And so it can be really, really important in terms of the populations you may be dealing with, because I know that all of your interviews, if I interviewed you and said, well, why do you want to be a PA? What does a lot of you say? I want to help the underserved. Well, how can you help the underserved if they're not counted, right? And they're not getting the funding allocated to them to pay professional PAs like you guys to come on and take care of them, right? These are things we have to consider in terms of like a socioeconomic sort of impact of this kind of stuff. And I'm sure, right, all of you probably said that, right? Yeah. That's what I hear a lot. I want to go work the underserved. And I was like, okay, we'll see where you end up. We'll see. Anyway, I won't comment any further. We see the data, we see where you guys go after you graduate, and so it's very interesting to see how things change over time. You all go and do great things no matter where you end up at, so that's all that matters. Anywho, so again, when we're looking at the health-related sort of data, again, information can come from simple examinations of the patients as that information gets reported out. Certainly they can go back to clinical records and information that's collected, say like as part of a hospital stay, for instance, or we may actually do studies of specific clinical populations, right? So we may actually hold studies, either retrospective or prospective, that goes and looks at these individuals, these populations more specifically. And again, when you're monitoring the health of very large populations, like an entire state, a county, a country, again, this is why these databases are so important, because it's much easier and faster to come up with answers than it would be if we just did the information ourselves. And so, as I mentioned, the federal government is going to be tracking lots of information here. So births, deaths, fetal deaths, marriages, divorces, all these things we collect data on, right? Some of it is reported through the CDC. Other organizations can be involved with this as well. Usually you're going to find state and local organizations will collect this data first, and then it gets transmitted up through the federal government. But again, all of these analyses are only going to be as good as the evidence that they actually have, the data that's actually collected there. And so there can be a lot of reason for errors, some of which we've already sort of mentioned there. So as I mentioned, unreported births or deaths, right? So again, if you're born at home and never got reported out that that birth had occurred, then maybe underreporting. The biggest one probably going to be inaccurate death certificate diagnoses, right? So someone says, oh, they died of old age. What does that really mean, right? Could be several different things that could be referring to. It all depends on who's actually doing the signing out of that death certificate, right? Could be erroneous demographic data, clinical data on the birth and death certificates. All these things could be inaccurate. And so one of the biggest problems we find is that underreporting is going to be a big issue, especially for a lot of the diseases that are things we want to monitor for. As I mentioned, the CDC is going to be playing a really big role in trying to track a lot of these things, and they can look for early changes, early kind of blips on the radar, so to speak, to see if they need to warrant further investigation specifically. And they'll actually send out teams to different places to look at these things potentially. But again, you're going to see that by looking at both local and kind of more widespread sort of information here, they can make these decisions to say, okay, well, is this something that's going to cross state lines? Is it something that needs to just stay as a local investigation? Does the government need to come in and actually look at this from a more state-to-state sort of standpoint? And CDC can kind of help out a lot with this. Here's some examples of different disease states that are considered to be mandatory reporting to the CDC. So some of these things sounds like it would be a pretty big deal if one of these cases popped up. So if you had an actual case of anthrax, something that'd be pretty rare, you'd probably be pretty likely to report something like that. Or say, for instance, you had a patient who developed, let's see, what's going on here? How about West Nile virus? You probably want to report that. So things that are like really kind of high profile or things that are very rare, they tend to get reported pretty easily. But how about things like, for instance, where's a good one? Like diphtheria. Like diphtheria may be something you see more in patients who are maybe not vaccinated, maybe something that you may not think so highly about, maybe wouldn't get reported out, right? So things that are common, things that happen a lot, tend to be underreported in a lot of cases there. And so very often we're only seeing a fraction of the actual cases that occur. So I'll give you a good example, at least one that applies to me specifically in the world of toxicology. So as I mentioned, poison centers are really important for collecting data on drug exposures, intentional, unintentional overdoses, things like that. And so if you are working in an ER and you have a patient that accidentally takes a double dose of their ibuprofen, and they come into the ER and said, oh my gosh, I took a double dose of ibuprofen, am I going to die? And you rightly would say what? No, go home. Get out of here. Take your ER copay and go home, right? Would you report that to the poison center? No, why would you, right? You don't need any help with that case. However, it is good that we get that information, right? Because we can look at the epidemiology of these things. We can look to see maybe there's something else bigger going on. So, and again, I'm just plugging the poison center because that's what I work with most closely. And I don't get paid for any of this stuff, right? Because again, we're supported or actually funded through the health department. But it's important to collect that data, right? So even if we have cases that are very easy or straightforward, you know what to do with it. It's still good to report that sort of thing out, so that way we at least know who actually is being exposed, right? We know who these cases actually are, and it lets us make better decisions on the whole, right? We're actually dealing with whole populations here. But again, extremely serious diseases, things that are quite rare, they get reported very frequently. However, other things may not be so much, right? So for instance, if someone gets diagnosed with a sexually transmitted disease, right? Some people may be hesitant to report that thing out because it could be isolating to the person, right? HIV is another good case of this, tuberculosis. So these are things that may be socially awkward potentially for the person to report out. Maybe they don't do that. And again, underreporting is only going to hurt the data overall. It makes it more difficult to do these investigations. So, but does that mean that just because we're underreporting that it's completely useless information what we actually do have to work with? No, because as long as the reporting trend stays relatively stable, we can still look for changes, right? So if all of a sudden we saw a big uptick in cases of syphilis that are above the normal, that could still be useful information, right? It may not be every single case of syphilis that's actually out there, but we can start to look for those trends there to see kind of where the blips on the radar are, okay? So let's talk about some of the measurements that we're going to be looking at when looking at these epidemiologic studies. Some of these terms we've already kind of looked at, or some of them might be familiar with. We're going to look at them in the context of doing these types of studies here. So frequency, you might probably know what frequency is. What is that? Yeah, just how often something is actually occurring there, right? And so again, it could be the frequency of disease, could be death, could be injury, could be lots of different things we're actually looking at. And again, the point is to take that frequency, that numerator, and then compare it to the denominator, being the population who might be at risk for developing that condition there, right? And again, depending on what data we're working with, depending on what kind of questions we're actually asking, that denominator may change who the population is we're interested in. So now here's another one. So how do we actually track frequency? Well, what does incidence mean? So it's a number of new cases over a period of time, okay? So for instance, if we were to start time now, and now we're to track to see how many people fell asleep during my lecture, I could look at how many incident cases of syncope happen here due to my lecture, right? Now, if I wanted to say take a single point in time right now to see who's asleep, what do you call that? It's going to be prevalence, right? So that's the difference, right? When we're looking at incidents, it's going to be new cases. Prevalence is at a certain point in time, how many cases are already present there, okay? And again, this when we're looking at incidents, it's just that transition from well to ill, uninjured to injured, alive to dead, right? These are all examples thereof. Now, when we say prevalence, we're actually not referring to, it's actually not the most specific term we could be using. Most of the time when we say prevalence, we really mean point prevalence. So just saying it at a very specific period of time, let's say right now, 12:45 in the afternoon, that's a point prevalence for whatever we're counting at the time. There's also what we call period prevalence. Anyone know what that means? So over a period of time, you're counting all the people that are at the very start, how many prevalent cases you have at the beginning, and then you're also including any new incident cases during that time. And I'll show you a graph here that will show you kind of the difference between those and how we might use those terms differently to one another. So again, when we're saying the term prevalence, most of the time we do mean point prevalence. Period prevalence is just referring to people who had the disease at any time during the specified time interval. Okay. And so to give you an idea here about the concept of incidence, again, when we say incident cases, that's what we're referring to those new cases that happen over a period of time. We'll make better illustrations of this in the next slide. We're actually looking at this graph here. Basically, we're going to be looking at 8 different people during a period of time, some of which already have the disease in question, some of which will develop the disease in question, and some people may recover from it. And so we're going to be able to look at the different time points here to get a different idea what the incidence, prevalence, etc. is. So looking here, T1 is on the left, T2 is on the end of the time period on the right here, and you can see the individual patients included here, right? So for instance, for person 7, they ended up developing the disease state probably somewhere around March, April time frame, and then what happened around November? They were cured, right? Or it resolved, or whatever the case may be, the period ended there. How about person 1?
The whole time.
They had it the entire time, right? So you guys can at least read the chart here, and we can make some different inferences about this when looking at it. So again, person 1, they had the disease state the entire time, they had it when the period began, had it when the period ended there. For 2, 6, and 8, what about them? They had it at the very beginning, but they resolved somewhere during that interim period there. Okay, 3 and 5 would be what? Yeah, they started the disease state sometime during the period, and then they still had it towards the end there. And then 4 and 7, they caught it and then resolved it within that time period. Okay, so the question would be, let's say, how many incident cases occurred during this time frame? We would look at all the new cases that actually happened here, right? So we're saying incident cases. So how many incident cases do we have?
4.
1, 2, 3, and 4. We have 4 incident cases here. Okay. What would the point prevalence be at time 1? Be 1, 2, 3, and 4. It's all the people who had the disease state at that one particular period of time. Okay. What would the point prevalence be at the end of the study? Be 3 people who still had the disease state. Okay. Now, what would the period prevalence be for this? It'd actually be all 8 of them, because again, all 8 people either had the disease at some point during the time period, and that makes them all part of that period prevalence. Does that make sense? So we can see the difference between those.
So the idea is to be able to capture a better picture of how frequent the disease actually is.
Yeah, so for instance, say you're doing a prospective study, it may make more sense to look at incident cases, right? So say for instance, you want to organize people by risk factors. You want to do a cohort study, and some people have the risk factors, some people don't, and then you follow them forward to see how many new incident cases you have, right? Sometimes you may just be doing an observational study where you're just looking to see, some people may have had the disease state in the beginning, and you're looking to see new incident cases as well. You can talk about that period prevalence. When do you think we would use point prevalence? Those tend to be good for retrospective studies. So for instance, if I'm doing a case control study, and say I was looking at, for instance, let's say there's a food truck that stopped here every day. So say there's a food truck that stopped here at 12 in the afternoon, and then all of you went to eat at the food truck, okay? And let's say some of you developed nausea, vomiting afterwards, okay? Say 2 hours afterwards. And let's say maybe 20 of you got nausea, vomiting, the rest of you did not, okay? We could do a case control study off of that, right? So we're starting off with the disease state who had nausea, vomiting. So those are our cases. The controls would be people who did not. And then I could look backwards in time to see the prevalence of who ate what, right? So the people that got the sushi, maybe 15 of the people that developed nausea, vomiting had the sushi from the food truck. Is food truck sushi a good idea? Who could say? In this case, maybe not. But let's say 75% of the people who got sick had the food truck sushi. Maybe only 10% of the people who didn't get sick had that sushi. That would be the prevalence of the number of people who actually were exposed to that risk factor, right? In that case, their prevalence can be very useful. So typically with retrospective sorts of studies, you can use prevalence to give you an idea. Okay, does that make sense? Again, food truck sushi, I don't know, maybe there's some really good stuff out there, but who can say? Anywho, and so this is just kind of summarizing what we already talked about. So again, which ones are the incident cases, point prevalence, etc. We can figure that out. Okay, so again, looking at that relationship between incidence and prevalence, here's a good graph that kind of shows you this. So this is some information coming from the CDC, and basically is looking at the incident cases of patients diagnosed with HIV or AIDS from 1981 all the way up through 1992. Okay, now they stopped at that time frame because actually there's a big change in the definition of how you diagnose patients with HIV or AIDS. And so, if you remember, we looked at a graph last time with that. What happened when they made that change in definition? It's a huge spike in new cases, right? Because now you're capturing more people here. So this is why it's looking at a relatively short time frame, but we can look at the relationship between incidence and prevalence. And so looking at this, basically the white parts of the bars, the unshaded parts are going to be people who are alive at the end of the study. The dark shaded areas are going to be people who are dead at the end of the study. Okay, and so looking at this, the heights of the bars are reported cases for each of those years, right? So what do you kind of notice about this first year here? Everyone died. What about the actual reported cases? Relatively low, right? Why is that? So maybe there was not a lot of people who had actually contracted it yet. What else? We didn't even know really what it was at the time, so maybe there's a lot of underdiagnosis, right? You have someone who shows up with, relatively benign flu-like symptoms, like, could that be an acute retroviral syndrome, or could it just be they had the flu, right? So maybe they weren't able to capture these people effectively. And so what do you notice as time goes on, though? More and more people are being captured now, right? So we're now actually being able to identify those individuals who have the disease state. And so again, early on, what do you notice about the shading of the bars? All those people by the end of the study they were dead, unfortunately, right? And why do you think that was? Yeah, we didn't have any good treatments for it, and also perhaps we don't know how long those patients had the disease state already, so who knows how severely progressive they might have been at the beginning. But what do you notice as time goes on? More people look like they're alive. Why do you think that is? Maybe treatment. Also, what else? They may be like brand new diagnoses, right? They may be people who are just diagnosed at the end there. So again, if you were diagnosed in 1992, you might still be very early on. You haven't been in the study for very long. Thus, you would still presumably be alive, right? Versus if you were to say be counted in 1981, the idea of you living for 10 years with that disease state with no treatment, unlikely, right? That's why most of those individuals tend to be dead by the end of that period, right? So again, giving you an idea of the difference between the prevalence. And again, prevalence here is going to be the number of people still alive versus dead at the end of the study period versus incidence, which is actually going to be the height of the bars here. Okay, does that kind of make sense between the two? Hopefully. I still don't see a lot of light bulbs going off. That's okay. I think you have to get it to some degree. But in the full height of that bar is going to be the number of incident cases they had for each of those particular years there. But the prevalence at the end was basically if you added up all the unshaded parts of the bars together, that would be your prevalence of patients who are still alive with the disease state.
So this is that bar graph was showing how many cases each year. So like if somebody was diagnosed in 1986, they would not be included in the 1990 if they were still alive.
So if they're still alive, that's why it's unshaded, right? So that's why those small number of people are still alive at the end of the study period.
Okay, so it's like continuous, like you're continually tracking the same people.
Yeah, so you're just basically saying like how many people did we diagnose in 1981? How many people did we diagnose in 82, right? So the incident cases for that year of new diagnoses is the height of each individual bar here, right? But if you were to add up all the white bars, the white sections of the bars together, those would be the total number of people who had the disease state, they're still alive in 1992. That's the number of prevalent cases they have at the time, because all the other people don't get counted because they're dead, right? So again, that's how we're kind of looking at the relationship between incidence and prevalence with one way to represent the data, right? And again, I know it's not super uplifting information for your Friday afternoon, but again, this is a good way to illustrate the points, and this is what a lot of epidemiology looks at is, especially with these kind of really high-profile disease states where there's a lot of intense sort of study early on done back in the 80s and 90s, et cetera, right? But again, if you look at this, some of the areas, of the unshaded areas, those are going to be the number of AIDS cases as of that date that were still alive at that time. So that would be the prevalence of the disease state at that time. And so again, looking at the patients diagnosed between 1990 and 1992, again, they've had the disease state for a really short period of time, so it makes sense that they'd still be alive towards that time frame, versus those diagnosed back in 1981 where there's no treatment for it at the time. Again, that made sense why most of them, or almost all of them, were dead at that time frame, right? Okay. And actually, if you add up all those bars together, you can consider that the cumulative incidence over that time frame, say over that, say 10 years, 12 years, whatever the case may be, right? But then looking at this, we end up seeing that at the close of 1991, they had roughly 73,000 prevalent cases of AIDS. And again, that was based off the difference in the number here, the total number of incident cases minus those that had already succumbed to the disease. That's how they end up getting that actual prevalent number of cases at that time frame. Okay. But as I mentioned, the CDC made a big change in definition around 1993, and so because of that, they changed the criteria to actually diagnose the disease, so the actual incident or the prevalent number of cases actually went up pretty significantly there. Now, can you use that information, say, from 1985 to compare to information from, say, 96? Why not? Different definitions, right? So that's why you really have to look at it and make sure you're comparing apples to apples, so to speak, because if the definitions have changed greatly, your idea of what the actual numerator is has changed probably pretty greatly as well. So that's another really important concept when you're looking at things over time, is have the way we've diagnosed the disease changed. For instance, looking at cases of PE, say before and after the intervention of CT scans. How do you think that changed? The number of cases of PE probably went up after we started CT scanning those individuals. Why? We could see it, right? We can catch more of those individuals now, right? So again, comparing data beforehand to afterwards, the epidemiologic data may not be very comparative. And so it's important before you make any kind of inferences about that to understand what has changed in that intervening time frame, right? Just like back in the 1800s, people used to die of acute indigestion all the time. Do people die of that now? No, but they have a whole lot more heart attacks because we can diagnose that much better, so it's hard to compare those data points together, okay? And again, if you're looking at the number of cases here around 1993, you see this huge spike because more and more people were able to fit that definition and they're actually able to get that diagnosis, okay? So that's why it's really important to look at the time frame to see, like, what are you looking at, how things change during that time frame, either during diagnosis, either how treatment has gone. Because again, if you're looking at life expectancy before and after, maybe quite different because again, new treatments have come around, things like that, right? So, as you mentioned, the prevalence is going to be the result of a lot of different factors here. So it could be the periodic or annual number of new cases that occur throughout the time frame. Depends about the immigration and immigration of persons with the disease. What does that mean? People moving in or out of the population. So for instance, if we have a lot of people who are, actually this is probably important, especially if you're looking at like refugee communities moving into different populations. So say for instance, you have a lot of refugees moving into certain European countries, you may be able to see changes in the disease state based off of that, right? So that can be really important about who's moving in or out of the population. And then the average duration of disease, meaning the time from the onset until death or the healing actually occurs, is quite different as well, right? What do we mention about patients with HIV nowadays in terms of their survival prospects versus, say, back in the 80s? It's a heck of a lot better, right? Patients are now dying of other conditions like metabolic conditions like, heart attacks and diabetes, etc., because now they're living for a lot longer, okay? And again, that has a big effect on prevalence. May have more prevalent cases because more of these individuals are living for much longer now, right? So, and basically what you're looking at in terms of kind of a crude way to generate what the prevalence is you're looking at the incidence times the average duration of disease, right? So basically, how many people actually contract the disease times basically the average duration they're going to be keeping that disease for, either till they succumb to it or they recover from it, right? So what you end up finding is that formula works pretty well if the incidence of the disease and its duration in individuals is pretty stable over an extended time frame, right? Because again, we mentioned with HIV from the 80s to now, it's changed pretty drastically, but maybe for some other disease states, that's not been the case. And so incidence and the actual duration, they're keeping it. As long as that's stable, then that formula usually holds pretty well in terms of estimating what the prevalence is for a given disease state, right? And again, looking at that in terms of AIDS, could result of an increase in the number of new cases being diagnosed, like we mentioned, that definition changing in '93, or the length of the time that patients that are symptomatic still survive, mainly because they have a longer period of time due to better treatment. So, as you mentioned, the incidence of AIDS in the U.S. is actually declining because we're keeping more people from actually developing AIDS, right, getting those AIDS-defining illnesses. But the duration of life, as we mentioned, is extending. So even though the new incident cases are going down, what's happening to the prevalence? It's getting bigger because, again, more people are staying alive for longer in those cases there, right? Because we have better antiretroviral agents, because we have better agents to prevent against some of those opportunistic infections or some of the AIDS-defining illnesses, so to speak. And so because their survival time is much, much longer, instead of the incidence, even though it's going down, that part of the formula is going down, but the average duration they have is going up much longer. That's having an effect on the prevalence in the U.S., right? How about looking at cardiovascular disease mortality? If you're looking at age-specific incidents, and when I say age-specific, what does that mean? Yeah, it's not looking at the entire population, but looking at specific age groups, right? Because if you're looking at cardiovascular disease mortality in children versus adults, age has a big factor on that, right? So when you're looking at age-specific incidents, it's been declining in the U.S. However, the prevalence is not. And why is that? Because patients are living for longer. We have better treatment. We're giving them beta blockers and ACE inhibitors and all kinds of things like that. We have better access to percutaneous coronary interventions, and we have better ways to keep these patients alive for longer because we're forestalling death. So that even though the number of incident cases may be going down, people are living a lot longer in the disease state. So another factor here we're going to be looking at is going to be risk. And what is risk? Besides a board game. It's going to be the chances of you actually developing the disease in question, right? So again, do you have a 10% risk of developing gastrointestinal symptoms after having food truck sushi? Who can say, right? But you could do a study and find out what the risk is in those cases there, right? So again, risk is being defined as a proportion of persons who are unaffected at the beginning of the study period who undergo the risk event during the study period. We've talked about risk before, right? We talked about risk ratios and things like that. What type of studies normally work with risk? Usually prospective studies, right? Because we're starting with people who don't have the disease state in question. We may be categorizing them based off of risk factors, or we may be randomizing them to a group versus one group versus another. But risk is going to be typically done in these prospective studies to see who actually develops the outcome that we're curious about. And again, it could be death, could be disease, could be really anything we're curious about. But the risk at the beginning of that event study period is what we call this cohort, right? And so investigators will basically then follow that cohort, because we already talked about cohort studies already, right? They're going to follow them for maybe a several-year period, and they'll be able to look to see, does that event change, okay? Now, what are some things that could skew that? Obviously, if people are falling out of the study, that'd be one thing to be worried about. But remember what we said when we're dealing with risk, what is the denominator when we're making like those cohort studies? It's not like the whole population of a state or something, but it's basically all the people in that cohort that we've set up, right? So when you do that prospective cohort study, the researcher's saying, okay, these 100 people are my cohort. I'm going to look to see how many of them develop the disease state. And if 10 of them out of the 100 develop it, what's the risk? 10 out of 100 or 10%, right? So that's basically what they're kind of coming up with. Now, again, you can have that change a little bit. People fall out of the study, et cetera, but that's kind of what they're essentially looking at when they're setting up these cohorts here. Now, again, you have to be careful when you're applying these risk estimates, especially when they're derived from a population to your individual patient. And so this is part of what we talked about. We're talking about generalizability, right? So for instance, say the study we were looking at with the urine antigen test, right? And they were looking to see who got de-escalated. Now, if we had a patient who's having, say, a ventilator-associated pneumonia, did that study apply to that patient we may be dealing with in the ICU? Well, why not? Well, they got excluded from that study already, right? So you get to see, when you're looking at a bit of data, how does this apply to my patient? You know, if you were dealing with a patient who is 65 years old, and the study you're looking at only looked at patients 18 to 45, that may not be all that too generalizable to your patients. That's why it's really important to consider that. Now, again, what's the risk of death for any individual? It's 100%, right? Technically, your risk of death at some point in your lives is 100%. I hate to tell you, I'm sorry, this is the first time you're hearing this. All of you are going to die at some point. Well, I'll be very sad when it happens, though. But the better way to kind of pose it is when you're trying to approach a patient's questions, what are my chances for X, Y, or Z happening? For instance, you say they're worried about going to surgery. And you say, well, your chances of surviving surgery is 99%. What are they going to say? What about that 1%? What if I'm part of that 1%? Because everyone thinks they're special, right? Everyone thinks they're special. So I always tell students, it's like, you're not unique, unfortunately. You're pretty average, which is good because we have a lot of really good students here, which means if you're average, it means you're actually a really good student, right? But I always tell people if they're ever having trouble, it's like, you know what? You're average. It's okay. Everyone has trouble sometimes. But point being is that sometimes people feel like they're more special than they are, and they say, well, if I'm the 1%. So that may not really allay their fears, even though you tell them there's 99% chance you're going to survive. But you can't really say 100%, right? Because you never want to be 100% sure. It's the only way to be 100% wrong is to say you're 100% sure. So rather, it's better to make comparisons to say other things that may put it more into better context, right? So for instance, your chances of surviving surgery is better than if you were to take, say, a cross-country trip in an automobile of getting in an accident, right? People get in accidents all the time, probably more than 1%, especially if you're on I-4, right? The deadliest highway in the U.S.
Is it true?
I think that's...
Especially in Orlando too, like the stretch in Orlando is the most deadly highway for life.
Anecdotally, if any of you have ever driven on it, you must know this, right?
Yeah.
It is insane. I purposely drive ways just so I can avoid it if possible. Even if it takes me an extra 10 minutes, I'd rather arrive alive than drive on that horrible...
That's not understanding your chances of survival, though, right?
Huh?
Is that understanding your chances?
So that's interesting, right? So if I spend less time on the road, how does that affect my chances versus if I get on a more dangerous stretch of road? I don't know, right? If I call that Uber, I'm less likely to get a DUI, but maybe more likely to overdose on alcohol, right? Who could say? Until we do the studies. But who's going to fund that sort of thing? Maybe Smirnoff or somebody, I don't know. But anyway, point being is that sometimes it's good to relate these risks and percentages to something that's a little bit more relatable to these patients there. Because again, some patients may not be willing to take any risk, right? But we always know there's risk with anything that we do. So, and a lot of times it's difficult because you have to decide, what's the correct denominator that you're actually working with, right? So would it be correct to say that, the risk of anyone in this room developing cervical cancer is blah? Why not? There's a certain proportion of you that don't have a cervix. You cannot get cervical cancer, correct? Now, actually, like one of the first years I taught here, there's only 4 male students in the entire class. So that would have been a much better, closer denominator than if I was dealing with this class here, which is probably about a third. The class is not at risk. Make sense? Just like if I asked what's the risk of developing prostate cancer of the 63 of you? For some of you, you have a 0% risk of that actually developing, right? So again, it's important to consider what's your denominator, who you're actually working with. So again, of women who are at risk for becoming pregnant, even that has to be sort of applied logically given certain circumstances. So again, when you're looking at all women, can all women become pregnant? Well, no. What if I just said women age 15 to 44 years? Can all of them get pregnant? No. What if they had a hysterectomy? Maybe they're infertile for whatever reason. And so it's important that you consider what's the actual denominator? Who are the people who are actually at risk of having a disease state actually occur? And again, it'd be people with an intact uterus and people who are a certain age range, things like that. So sometimes those caveats are really important, especially when I'm considering generalizing information from a study back to my patient. So again, sometimes it's really difficult to tell who is truly susceptible. So for instance, if I say the risk of anyone in this room developing polio, or are all of you at risk for developing polio? Some of you may not be at risk because a lot of you are vaccinated, right? Maybe all of you are vaccinated, who could say? Not I. But point being is you have to consider what is your actual risk of the disease actually occurring there. Now, of course, it could be vaccine failures and things like that. But in general, most of you are probably not going to develop polio ever. Your risk is quite low because most of you don't really have much of a capability to develop it, right? So anyway, so the denominator usually is either going to consist of the entire population, that would include everyone, or you may be trying to focus it to a specific group, maybe those that lack antibodies. Maybe you've done blood titers to see, do you have any antibodies against polio? If no, then maybe you then are an at-risk population, right? So, and again, when you're looking at risk, so let's say, for instance, the risk of death from an infectious disease, it gets really complex because you have to consider kind of all stages of things. Just because you contract the flu doesn't mean you're necessarily going to be one of those patients that die from the flu, right? So for instance, you're looking at different subsets of the population to kind of get an idea of like, they can kind of tell you different aspects of the disease state. So for instance, you have people who will die from an infectious disease. You have some set of people who get ill from it, some people who are infected but never really manifest a whole lot of symptoms, and then you have people who are exposed to the infection but actually never contracted it, and then people who might be susceptible to the infection. Each one of these is a subset of the one below it, right? And again, which one is probably going to be the smallest subset? Probably the patients who actually died from this, right? And I'll show you a graph here, or a picture that kind of illustrates this. But again, it's important to understand how each of these are related to one another, so that way you can kind of make some assertions about the actual disease state itself. So looking at this, the proportion of clinically ill patients who die, that's called the case fatality ratio, right? So people actually contract the disease and got symptomatic and died from that. That's called the case fatality ratio. Obviously, the higher the case fatality ratio, what does that mean? The more virulent the disease is, the more serious it really is, right? The proportion of people who are infected who then became ill is what we call the pathogenicity of the organism, right? So if you catch the disease but you never manifest any symptoms of that, then it's not really that serious of a bug, right? The pathogenicity is not very high. But the more and more people that become ill, the higher that proportion is, the bigger the pathogenicity is. And then the proportion of exposed people who actually become infected is what we call the infectiousness of the organism. So how likely are you to develop it or to get infected with that organism just by being exposed to it? So this kind of gives you a good idea. Looking at the total population, the people who are actually susceptible to it, right? So maybe these include everyone who's not maybe vaccinated against the organism, and then those that are susceptible, those that may be exposed to it. So for instance, what's the likelihood of any of you being exposed to, say, malaria? Not great unless you do what? Unless you go traveling, right, to areas where that's more endemic. So already you may not actually be a subset of the people who might even be exposed to it. Are many of you susceptible to malaria? Certainly, right? But again, if you're never exposed to it, then it doesn't really matter. Now, again, getting into the actual pathogenicity, the actual virulence of it, those that actually get infected are going to be a subset of those that get exposed. And then looking at if you become ill, that has to do with the pathogenicity. And then finally, that case fatality ratio is that small subset of those who actually became ill, who actually died. Okay? And so we know that risk itself as a concept has some limitations there. So for instance, as an example we're going to be using here, we're talking about 3 different nursing homes. And again, I hate to be a Debbie Downer, but we're going to talk about death a lot more as the course goes on. But let's talk about, think about your grandparents. Maybe in these nursing homes. I'm just kidding, don't do that. I've lost all my grandparents, I'm already jaded by it. But let's assume we have 3 different nursing homes. And they're all the same size, and the age of all the occupants are roughly the same, right? They all have the same distribution of inhabitants there. And so let's assume they get no new patients. So we're all full up. We're not going to get any new patients, any new customers during the study period, right? And we're actually going to be looking over 1 year period. And they have the same overall risk of death. Let's say, for instance, it's 10%. Now, would you let your grandma go to a nursing home where they said, our advertised risk of death is 10%? Not usually something on the brochure, but let's say we have some background information. We say, okay, it's 10% for all 3 of these nursing homes here. Again, we're looking from January 1 to December 31st. And what we're going to find is that despite the similarity in risk, the death, actually the where the deaths occur can be quite different in the different nursing homes, as we're going to see here. And so let's say for population A, and I'll show you a graph in a moment here, they had a really bad influenza epidemic during the very beginning of the year. And let's say all 10% of their individuals died during the first couple months. But then everyone else stayed alive the rest of the time. Okay? Let's say that influenza epidemic did not hit population B until, say, December, so the following year, and then all 10% of their people died right at the very end. Okay? And then C was not really hit with any epidemics of influenza. Maybe they did better hand hygiene, who knows. But they had a very consistent rate of death throughout the whole period there. So overall, the risk of death is still what? 10% regardless, even though the patterns of death were quite different amongst the different organizations. And so that's why, even though they're very different, using a 10% risk, it sounds like it's the same for all 3. So it doesn't really tell us as much information as we could. So we're going to be looking at something called the force of mortality and seeing how that has an effect on which part of the study period we're looking at, right? So the force of mortality for group A is going to be really early on versus group B is going to be really towards the end of the year. And so how do we actually account for that? And so we're going to get into something called the idea of rates. Rates is what we're going to be referring to when we get into that. So you can see here in this graph, again, 90% survival for all three groups here. But again, group A, you notice here they had the majority of their people die right at the very beginning, and it stayed relatively stable towards the end of the period. C was consistent all the way throughout, and then B was kind of consistent all the way to the very end, and then they had all their people die off. Okay, so again, overall, what's the risk of mortality? 10% for all three of them. How do we quantify the fact that A had all their people die off very early on versus B had all their people die off towards the end? That's what we're going to talk about rates. And so I'm going to use that as my cliffhanger to let you go on a 10-minute break. We'll come back and continue talking about nursing home deaths. All right, let's continue on. So we're talking about the force of mortality and how it can differ amongst three similar populations that have the same risk. And so how do we actually quantify that? And then, again, as we mentioned, we're going to get into rates now. And so rates are going to be calculated a little differently in terms of how you would normally calculate a risk. So a risk in the case of any of those nursing homes would be calculated by what? So they have 100 residents in each one. The number of people that died over, what number would I use? 90? 100, right? We're not looking at the odds of death in that group. Odds would be 10 over 90, right? But the risk of death would be 10 over the whole population at risk, right? So it would have been 100 in that case there. So 10 divided by 100 is 10%, and that's how you end up getting your risk. That rate is going to be calculated a little differently, and we'll look at what that is in just a moment. Basically what it's going to be doing is instead of using the entire population that's at risk, it's going to be looking at the average number of people at risk during the time period. Okay, so it's subtly different, but certainly different. We're going to look at what that is in just a moment. So what we can do in order to get that average number of people at risk is instead of using the entire population number as our denominator, we're going to have, and I forgot to put it in presentation mode, my goodness. I'm so sorry, let me restart. No. Just kidding. So what we're going to do is use our midpoint population for that. So basically, if we're looking from January to December, I'm going to basically use that population around the June, July sort of time frame there. Okay. And so again, if you look at this graph here, you can see that that midpoint population is quite different between these, right? So looking at this, we would see who would have the smallest denominator in their rate. It would be group A, right? Because they had the smallest mid-period population because when did all their people would die off? Towards the beginning of the year, right? So in this case here, their rate would be 10 over, say something like, what? Like 95 or something like that, right? Because 10 of the people died during the whole time. Or actually, we'll look at the number, maybe not 95, maybe close to like 92, something like that. We'll look at the numbers in just a moment. But again, that smallest denominator means they're going to have the smallest or the biggest rate. So if I shrink the denominator, bigger rate, okay? Basically what that's trying to illustrate is that a lot of their people died off early, meaning that there were fewer people at risk of death because all the death had already occurred, right? So they're going to have the biggest rate because all that stuff happened early. Who would have the smallest rate? Group B, right? Because all their people end up dying off at the end, and their mid-period population is going to be the largest. Obviously, Group C is going to be right there in the middle between the two. And so basically that's what we're going to be looking at is that mid-period population. That's how you should be able to calculate a rate, okay? Now, I could give you a question on an exam, and again, I would make it very easy math, but I could say, what is the rate of death in this population, say of 100 people? And I would give you basically the calculation for the risk, I give you the calculation for the odds, and then I can give you the one for the actual rate. And you should be able to figure that out based off what your denominator is. Make sense? I hope it makes sense. We'll look at some more examples here in just a few moments. But anyway, and again, we'll have a review that will cover a lot of this as well. Anywho, so looking at this, how we actually express this though, because again, would it be right to say that, you know, the rate of death was 0.85? Like, it doesn't really make a whole lot of sense to people when you express things like that. So normally what we end up doing is our rate is going to be multiplied by a certain constant multiplier, and it's going to be by a certain number of population, as we're going to see here in just a second. Typically, instead of expressing the rate of death as a percentage, what we can do is multiply it by say something like a 100 multiplier. So for every 100 people, this many people end up dying. For every 1,000 people, this many people end up dying. That way, it kind of makes more sense when you're explaining to someone who is not an epidemiologist how they actually equate that. So if you say, well, 0.85 of a person died, doesn't really make sense. Versus if you can say 85 people out of 1,000 end up dying, right? That makes a little bit more sense, as you're going to see there. So 1 death per 1,000 people per year is another way you could express that potentially. And so anytime you're using a constant multiplier, you're going to multiply both the numerator and the denominator by the same number there. So that way the numbers stay consistent, okay? That way you don't end up getting something kind of wacky out of those values there. So other ways we can look at that. So for instance, we can look at, say, the crude death rate. We'll express why we use a constant multiplier. So for instance, say in 2003, the rate for the US of death was 0.0086 per year. And again, if you're trying to express that to somebody, it doesn't really make a whole lot of logical sense, right? Intuitively, it doesn't make a lot of sense. But it's easier if I multiply that by 1,000, then I could say it's 8.6 deaths per 1,000 individuals per year. That makes more sense. You can somewhat imagine 8.6 people out of 1,000, right? What would be another way I could express that? 86 people out of 10,000, right? That way you get rid of that kind of a fraction of a person. Can you have 0.6 death of a person? Just the lower 60% of you died off, but the upper 40 we were able to save. Doesn't make a whole lot of intuitive sense, even though those are the numbers as they are. But again, by multiplying by, say, 10,000, 86 per 10,000 people per year makes a little bit more sense. I'm sure you've heard rates like that expressed before, you know, this many people per 1,000 people per year, right? Anyway, the number of deaths by the mid-period population, this is important. That's actual what makes it a rate as opposed to just a risk, and then times 1,000 as your constant multiplier. So looking at the relationship between risk and rate, we're going to see that rate can be beneficial in some circumstances, risk might be bad in other circumstances. We'll kind of compare that. So in that nursing home example, populations A, B, and C, we said were all similar in size. Each had a 10% overall risk of death in the same year, but we saw that the pattern was certainly different between the three of them, right, where the deaths actually occurred there. And so we'll look at the next slide here to look at the different patterns and illustrating how that has an effect on the risk. Again, knowing that Group A had the lowest midpoint population, Group B had the highest, and seeing how that actually affects the true risk there. And so because most of the deaths happen for Group A happened at the very beginning, before July 1st, their mid-period population was the lowest, and that's just going to be shrinking their denominator, thus the rate is going to be higher for them. They're going to have the highest rate, right? So maybe it's 10 over 92. Now again, 10 over 92 is still pretty close to 10 over 90, right? So in some cases, the rate and the risk can actually look somewhat similar to one another, but they will be different, especially depending on the size of the population that you're dealing with. Versus B, we said would have the highest or lowest rate. B would have the lowest rate because their mid-period population was the largest, so say 10 over 98, for instance, right? It's going to be a little bit farther off from the actual risk of 10%, as you would see there. And then C would obviously be somewhere in the middle since their mid-period population was pretty steady all the way throughout there, okay? And so again, even though the 1 year risk was the same between the three, the rates, as we mentioned, are going to be pretty different there and give us an idea of, in terms of the timing, when the deaths actually happen. So we'll see that rates frequently get used as a estimate for risk. And the rate's going to be a good approximation of risk if some of these things have to be met, okay? So if the event in the numerator occurs only once per individual, that's going to be a good estimation there, right? So if people could die multiple times, it doesn't really work for us. We'll talk about how we count things that can happen multiple times. So if you might imagine, like, people get infections, they get reinfected. We'll talk about different ways to calculate that. It should be the proportion of the population is pretty small. So it's good if it's like an event that happens less than, say, 5% of the time, which wasn't really true in our example here just a moment ago. And then also if you're looking at a very short time interval, okay? That's also going to be good. Like for a year or less, typically is going to be a good time for your risk to be very similar to your rate. And we'll look at why that changes over time in just a few minutes here. And basically, if the time interval is long or the percentage of people who die is quite large, the rate is going to be noticeably larger than the risk, right? Because it makes sense, because then your mid-period population is going to be far different as you either go for a long period of time, or if that rate is going to be quite high just due to the number of people, the actual risk of it actually going up there. So if it was like 25, 30%, then it's not really going to be all that close. So, and to be valid, for it to be a rate, it has to meet certain criteria between the numerator and the denominator, right? So this relationship has to be accounted for. So again, all the events counted in the numerator has to have happened in the pot, and people actually counted in the denominator. Why is that? Because you want to include other people that weren't actually part of that population at risk. So that's a pretty straightforward kind of one there. And then second, all the people counted in the denominator must have been at risk for the event, right? So for instance, if I was looking at the rate of cervical cancer in that same population of people who live in the nursing home, that would not be valid because I'd have to look just specifically at the females, right? Could include males in that sort of calculation there. So again, there might be a question on the test asking you which one of these is a valid rate. And so you'd have to be looking at, does it make sense, physiologic sense, for this outcome to occur for the population that you're interested in? Okay, so I was looking at prostate cancer in the US population. Is that a valid rate? No, I should be looking at prostate cancer in males that live in the US, or people with prostates, I should say, in the US, right? If I was looking at, say, for instance, I'm trying to think of a good example. I'll come up with some examples as we go along, but just keep in mind, there'll be other examples there. But looking at this, we can see that the denominator has to make sense based off of the number of people who might actually be at risk for it. Or let's say, for example, the number of automobile crashes and people who commute to work. You know, would it make sense for people to, say, ride their bike to work if you're looking at automobile crashes? Well, not really, because they're not really at risk for an automobile crash because they don't ride an automobile, right? Those are things. I'll be pretty clear on the exam because, again, I've asked that question several times already, and I've gotten students questioning it every year, so I've really kind of narrowed it down, so it's really unambiguous at this point, but there might be a question like that on the exam. Anyway, before the comparison rates can be made, also you have to make sure this is true, that the numerators of all the groups being compared have to be defined or diagnosed in the same way. Okay, so death is pretty easy. That's a yes or no kind of thing there, but let's say you were looking at, say for instance, pulmonary embolisms, and one group didn't have access to, say, a CT scanner, while another group did. Well, could you compare rates together at that point? No, because the diagnosis is being made totally differently, right? Or say if you're looking at different time frames where maybe certain diagnostic abilities were not available, or maybe new ones were available at the time the case may be. So that's one thing to note. The constant multipliers should also, the same ones need to be used. So we're not saying that, 8.6 people per 1,000 people per year versus 92 per 10,000 people per year, right? You want to make sure that the constant multiplier is the same between the two, and also the time intervals need to be the same when you're making comparison between different rates. Why does the time interval make sense to be the same? Because the longer the time frame goes, the bigger your rate changes from the risk. So again, when you're making those comparisons, you want to look at similar time frames, hopefully the same if you can, but if it's a little different, that's all right. That's generally what you're going to be looking for there. And again, as mentioned, the numerators may not be easy to compare depending on the medical diagnosis. So for instance, I mentioned the people back in the 1800s did not die of myocardial infarction. They died of acute indigestion. Now, if you were to look back at all those patients, can you just say back in the 1800s that everyone who died of acute indigestion died of a heart attack? No, it could have been a lot of other things. It could have been a AAA, could have been many different things it could have been dying from. And so it's really hard to look back at that to say, well, what was the actual rate of people with MIs back in the 1800s? You'd have no way to know, right? Unless you can make a time machine or something. And so then the period becomes reversed, so where again we have the ability to detect heart attacks, and so no one really dies of acute indigestion anymore. Okay, and so it's easy to make those kind of false assumptions, but again, what's the problem making assumptions? We just don't like to make assumptions, right? It's always good just not to do it. You usually end up with egg on your face, so to speak. But let's look at another case here. So another example of problems when you're looking at, say, the causes for disease, you're looking at how the factor that time can play as time goes on. So for instance, in 1948, there's a big revision in the International Classification of Diseases, or the ICD. Now what's ICD important for? Diagnosis codes. That's how you get paid, right? So that way you make sure you have appropriate diagnoses for your patients and make sure you code them appropriately, so that way you get reimbursed appropriately. And again, you'll have a whole thing on that. Professor Gerke does a whole Game of Thrones game with you guys on ICD-10 codes. Those are pretty fun too, especially when you look at the really wacky ones, like people that are bitten by like platypi or something like that. Like they have codes for everything essentially. But anyway, what they found was that when they made this major revision, they followed by sudden major changes in reported numbers and rates of many diseases. Now, do you think magically, just because they introduced this new classification, the actual rates of diseases were changing? Probably not. But again, how they get classified certainly may have changed, and that can make it very difficult when you're trying to look at historical sort of information there. So it can be difficult to look at causes for death over time, because maybe you're looking at two different classification systems, maybe you're looking at two different types of numbers you're dealing with there. It's really hard to make fair comparisons for cause-specific rates between populations, especially between two different countries, right? Because again, how they classify things may be totally differently, how they diagnose things may be totally different, to where it's hard to make, comparisons between, say, like an underdeveloped country versus a more developed country, right? So imagine, is it easier to diagnose, say, like a PE here in the U.S. versus, say, a third world developing country? Probably here, because we have access to more resources to make that diagnosis, right? So we can be sure that that's truly what it is versus somewhere else who may not have that ability, right? So just access to medical care can be very different, can affect these comparisons there. So those are the big things we're going to be looking at. And again, styles of diagnosis can be quite different between the two as well. So other things we're going to be looking at, so types of rates. We're looking at incidence rate. It's going to be very similar to what we already looked at. This is where we're calculating the number of incident cases over a defined study period, and then you divide it by what? The entire population? Midpoint by. Anytime you see rate, just know the denominator is going to be the midpoint of the study period. Okay? So if it's over a year, when do you do the midpoint? End of June, beginning of July, right? And again, that usually gets expressed by one of those constant multipliers, so per 1,000 people per year, per 10,000 people per year, etc. The difference here, though, with prevalence rates, actually not true rates, they're actually more of a proportion. They're going to be indicating the proportion, or basically the percentage, of persons with a defined illness at the time that they are studied. So again, if you were to look back to what the prevalence rate of disease was for a group of people at the beginning of the study period, and say 10% of the people had it, 90% did not, and that prevalence rate just tends to be 10% at that point. So it's a little bit different in terms of how it's calculated. Prevalence rates can be different from the incidence rate, so kind of keep those two straight. So, so this is important. This is going to be good for counting things that can happen multiple times. So we mentioned that rates are good if it can only happen one time to a person, so like death is a good example. Let's talk about incidence density of a frequency, right? Basically, when I say density, that just means how frequent it happens during a study period. And so typically we will express this as per person months or per person years. And so in a good example of this would be following, say, several patients for different periods of time to see how frequently they come up with a certain diagnosis. So let's say we had 3 patients who are being followed after TNAs, and we want to see how frequently they have recurrent ear infections. And so let's say, for instance, we had one patient that we followed for 13 months, one we followed for 20 months, and one for 17 months. And during that time period, we had 5 ear infections that occurred, and those 3 patients during that time, will basically just kind of add those time frames up, and that's going to be your the total time frame there. So again, 13 plus 20 plus 17, you know what that turns out to be? 50, right? So you can say 5 cases per 50 person months, right? So if you follow one person for 50 months, assuming they acted like these individuals, they would have 5 recurrent ear infections. If I followed 5 patients for 10 months apiece, each one of them would have 1 infection, right? So that's another way we can express this, okay? You may also change it up, so instead of saying 5 per 50 person months, you could say 10 infections per 100 person months. Sometimes it makes a little more intuitive sense to kind of think about it in terms of here per 100, how many infections will they get per 100 months essentially. Does that make sense? So again, you kind of extrapolate. It's a little fuzzy, but that's how oftentimes we can relate things that happen multiple times over a period there. And again, you can follow people for different periods of time as long as you add them all up to see what the total density is of that diagnosis. That's how you relate that. Okay, so incidence density, very useful when the event can occur more than once. So otitis media is a good example. Could I use MI? Yes, people get MI multiple times potentially. Could I use something like pregnancies? Yes, that can happen multiple times. Could I use, let's say for instance, hysterectomies? Why not? You only have one, right? That's taken out. That's done. Right, so you get the idea. Can happen multiple times. Incidence density is going to be a useful count for that. Okay. So looking at this, how do we actually use these rates? So you guys are like, well, who cares? Ultimately, yes, ma'am.
How do you make them valid for like if you disclose in the factors?
How do you mean?
Like if like for your interactions, maybe people have like different.
Yeah, certainly. Yeah. So and again, using 3 people to make any kind of like actual generalizability, that probably wouldn't be a good idea, right? But if you're doing, say, a small study and you're looking at, say, like a novel surgical technique or something like that, maybe there's a new way you're doing the TNAs, maybe that's how you start off a study, but then you could do it, say, with a larger group later on to kind of get a little bit better causal sort of analysis there. But certainly when dealing with 3 people, I mean, who knows, one of them could just be really more prone to it than others. But again, there's really more to illustrate the concept than anything else, for sure. But anyway, so what are we going to do with these rates and risks once we actually develop these? Well, we can use them to make kind of 3 different types of comparisons here. So first off, we can look at an observed rate or risk with a target rate or risk. So we can kind of see, say we want to set a certain target. We want to say we want this many people to have this percentage of outcomes and see how we compare up to that. So for example, the U.S. set a national health goals in 2010 and it included expected rates for various types of deaths such as infant mortality rate. Okay. We'll talk more about infant mortality rate later, because again, this is a very uplifting sort of class here. But again, why do we care about infant mortality rates? Yeah, it basically tells you the overall health of a country. So assuming your infants are surviving for longer, you're probably providing better care for them, for the moms, for society as a whole. So that's, again, sort of a surrogate count, but that's one thing we'll be using there. And so what they can do is they set certain goals from the government, and then we can actually compare our rates compared to what the actual happened to what they actually set that as. And so then see, like, did we meet up to that? Did we not? Why are there disparities between the two? Did we do better? What the case may be. So that's one way we could actually use those rates to make a comparison. A second type could be between 2 different populations at the same time, right? So this is probably the most common ones you're going to run into, right? So for example, if we want to compare the rates of death or disease in 2 different countries, or say different ethnic groups during the same time, we can start to make those comparisons there, right? Or say we want to compare the results of treatment between treatment and control groups. So say we wanted to do a randomized controlled trial, that could be an example of comparing the rates between the control group and the treatment group. And again, this is why a lot of major research is kind of focusing on this, looking at 2 populations that are similar, and again, make sure they're measured in exactly the same way, and that makes it an even better rate, comparison of those rates there. And then that third type is if we're going to be looking at the same population at different time periods, right? So why would we care about this? Well, look to see how they're evolving, right? Look to see, are people getting sicker? Are they getting healthier? How might that change? But again, we've already talked about how time frame can make a difference, like how you diagnose things, how you treat things. That can be really important. But we can look for trends over time. We can look for these adjustments here to see, like, are disease rates really changing, right? We can look at things like the incidence rates of HIV back in the 80s versus now, right? We can look at things like that to see these changes over time. But again, beware of the difference in diagnostic capabilities or treatment capabilities and how that might be influencing those rates. So from there, you can kind of make different types of rates. You can kind of adjust them a little bit more specifically. So we're going to talk about crude, specific, and standardized rates. Again, what do you think crude rates are? They're just basically going to be just the blank numbers, right? They're not really going to take anything else into account. It's like if 10% of the people died, 10% of the people died. We're not going to adjust for anything, any factors there. And then we're going to be able to see how we can adjust to make them more specific or standardized as the case may be. So I'll give you an example of why this matters in a moment. So again, rates that apply to an entire population without any reference to a characteristic of the individuals in it can be the crude rate. So for instance, you could look at the entire population of the US to see what the rates of MI were, but then, well, what if you were to divvy it up based on male versus female? Think those rates would be different? Right, so that could be a sex-specific rate. See the difference? When you're looking at crude rates, you're kind of looking at everyone, not adjusting for any factors there. What if you wanted to look at MI in children versus adults? That would be an age-specific rate. Okay, so it's kind of the difference. When you start to control for some of these factors there, that's when you get into more specific rates. And again, when they get divided into more and more homogeneous subgroups with particular characteristics that matter depending on the disease state, depending on what you actually care about, that's when you start getting those specific rates there. We'll talk about standardized rates a little bit later. So As you mentioned, crude rates can be really misleading, right? It can be really tough to say that, okay, well, the rate of death in the U.S. population is X. Would you really care what the rate of death in the U.S. is overall, or would you care about what those specific causes of death are? You probably want to know what the causes are. Why are people dying? Is it because of a bunch of opioid-related deaths? Is it because of automobile accidents? Is it suicide? Murders might be a good one to know as well. Who could say, right? Or maybe you don't want to know the entire U.S. population, but maybe you want to know specifically the town you live in, right? Would you want to know the murder rate of the U.S. or the murder rate in Orlando? Well, if I'm going to be spending 2 years here, perhaps I want to know what the murder rates are there. Or maybe you want to get away with murder. You want to go somewhere where there are already a bunch happening, and then you'll just fly under the radar.
Oh.
I'm going to cut that part out. But, so let's look at some comparisons here to see why we might want to adjust for these things here. So try to guess which of the following 3 countries, and don't look ahead, just ruin it for yourself. Which of the 3 countries, Sweden, Ecuador, or the U.S., has the highest and lowest crude death rate? What do you think? Who's the highest?
U.S.
The U.S.?
Yeah. Crude.
Who's the lowest? Sweden? Interesting. Let us see. Well, actually, I put it on the same slide, so I guess it wasn't that much of a surprise. So, you guys don't even read the slides anyway, so it's okay. Really, there's too many words. No thanks. So, but in 2004, they actually found Ecuador had the lowest crude death rate. Sweden had the highest. So you guys were completely wrong. Why do you think that is? We got to look at some of the specifics, right, huh? Could maybe population size, but again, you're just looking at the rates for the entire population, right? We got to start looking at different factors there, right? So you have to start to look at things like, well, what's the average age of the population in these different countries? So if you have an older population, what do you think that does to your death rate? It increases it. If you have a younger population, it decreases it, right? Because younger people are less likely to die than older people. I pray this is not the first time you've heard this, but you probably know this, right? So anyway, so because it doesn't take age into account, comparing these crude rates doesn't really make a whole lot of difference, right? So that's why it's really important to get into more of the specifics there. So for a population, when you're looking at the young age distribution, such as Ecuador, their median age is 23 years, right? Kind of similar to you guys. The birth rate also is going to be what? If you got a bunch of 23-year-olds running around, they might be more likely to have a bunch of kids than say if that median age is older, right? Just how it happens. And so that also affects their crude death rate, makes that lower as well. And so if you're looking at older populations such as Sweden, where people are living for longer, their low crude birth rate and high crude death rate would also be expected, right? Pretty healthy people, good health care, they're living for longer, so their overall death rate tends to be higher, but it's because their overall average age or median age tends to be older as well. And so because age has such a profound influence, we know this, that's why you need to make sure you're looking at the age-specific rates there, right? And so you should never make comparisons just on these crude values together without, you don't want to make any kind of good assumptions off of that, because they're not really factoring all the most important things. So looking at the crude death rate, you see Ecuador had the lowest, U.S. in the middle, Sweden the highest, but then also look at the life expectancy at birth. Several years older for the Swedish people. So they had more people that are living for longer, thus that was skewing up their average age, thus more of those people are probably going to die anyway, right? So how can we factor for that? We look at age-specific rates, right? We could take the effects of age out of it, so that way we can at least have a little bit better comparison between the two there. So again, why not avoid crude rates altogether and use specific rates? Or there may be some circumstances where it's not really possible to know that, right? So for instance, if we don't know the specific rates for the subgroups of the population, we don't know, right? Some countries may not have that information very well documented. They may not have that information available to other people, potentially, who knows? Also looking at the size of the subgroups is unknown. If you don't know what the proportion of people are that are aged 1 to 12 versus those that are, say, 20 to 40, it's hard to know what those denominators are to get those specific rates. Or if the numbers of people at risk are so small, that doesn't really give you good stable estimates, right? So if it's in a very rare event or something that happens very infrequently, that can be really difficult to look at too. But if the number of people at risk is large in each of the subgroups, you can find the specific rates do provide kind of the most information. I'll show you some examples of that in a moment. So how do we figure that out? Well, remember there's also a biasing effect of age, so what we can do is develop what we call age-specific death rates. What we can do is kind of divvy up the population into different age categories and figure out what their specific death rates are. And then based off the proportions in the population, we can kind of come up with a little bit better estimation here. So how would we calculate this? And again, you already know how to do this, but by looking at the number of deaths in a people of a particular age group, so say looking at 20 to 30, or say 21 to 30, 31 to 40, etc., and then dividing that by that mid-period population so that we know we're dealing with the rate, and then multiplying that by the constant factor, that'll give us a little bit better estimation of per age group, what's that death rate. And so basically what you're going to do is taking those crude death rates, you're basically kind of summing up all those age-specific death rates in each of the groups, and then weighting them by the relative size of each of the age groups. So in Ecuador, which age groups do you think had the heavier weights? Younger populations, right? Because their median age was younger. Versus in Sweden, the heavier weights were more assigned to the older groups, okay? And so, again, how we're going to be coming up with that is basically just summing up all this together. We're taking each of the age-specific death rates, multiplying that by the proportion of the population or the given weight of it, and then adding them all up together, okay? So don't be scared when you see that sigma. It just means we're adding them all up together, so not too big a deal there. But again, it can kind of give us an idea why those crude rates can really be misleading if it doesn't take into account the actual individual specifics of the population there, okay? So for here, when you're involving these two populations, you gotta know the relative weights or the relative sizes of each of the individual groups there, know what the numerators, know what the denominators are, and that way you can get better comparisons. So also think about this. So we have similar problems that come up, and this is something that actually could apply to where I work. Say we're comparing death rates in different hospitals to measure the quality of care. So let's look at, for instance, say like the neonatal intensive care unit at, say, Arnold Palmer Hospital versus Nemours Children's Hospital. So assuming we're providing similar care, who do you think would have worse outcomes? You guys don't know this right now, but basically if you look at, say, Arnold Palmer, what is attached to Arnold Palmer? There's also Winnie Palmer, right? That's where all the ladies give birth to the babies. They give birth to healthy babies and sick babies, right? Some of them end up in the NICU. Now over at Nemours, we're just specifically a children's hospital. Do you think we get anyone giving birth over there? I sure hope not. If we do, we're like, we need to transfer you out like now, like you need to go. However, though, which babies do we get coming to the NICU? We get transfers in from other hospitals, or maybe they show up as, say, an outlying adult hospital. They say, we can't care for this child. They're too sick. They get shipped over to us. So we think it happens to our death rates there. While still low, it looks like we're providing worse care, but really could just be we're dealing with a sicker population, right? So these are factors you have to take into account. If you just look at the crude rates and maybe they'll say, oh, look, our patients are so much healthier here, they have so much better care, but also they're dealing with a lot more healthy patients than they are sick patients potentially, right? I don't have the specific numbers, but it makes intuitive sense based off who our patient population is, right? And so looking at that, hospitals that care for the sickest people will be at an unfair disadvantage. If you live in, or work at a level 1 trauma center and you're getting all those level 1 traumas in, are those patients more likely to die than if you were to, say, a non-trauma center? Well, yes, it doesn't mean you give any worse care. You may actually give better care, but it's just your patients are sicker, thus more likely to die. So getting into that, we can get into what we call standardized rates, otherwise known as these adjusted rates, right? So they're going to be crude rates that have been modified or adjusted for a particular effect size, right? So we can be looking at the age, you can be looking at gender, you can be looking at all kinds of different disease states, all kinds of different factors here. The most common one you're going to do, though, in the example of looking at Sweden versus Ecuador, you're going to find that the age standardized or the age adjusted ones tend to be kind of the most common. There's a couple ways you can actually come up with this, but we're going to look at the standardization, how we apply it to the death rates, and it'll allow us to kind of make a better comparison between the two populations. So we're going to find the direct standardization is probably the most common method we're going to be using here, and again, it's removing the biasing effect of the differing age structure of the differing populations. So just because Ecuador has a much younger population, Sweden has a much older one, you're trying to take out the effect there, right? Because if you just looked at the crude rates, what do you call age in that situation? It's a confounder, right? You didn't take into account the actual breakdown of the population in terms of age. And so the direct method, basically, we're going to take those age-specific death rates of those individual population, like the actual subgroups there, two or more of the populations, and then compare them using an applied single standard population. So you can look at the age-specific death rates for those different groups and then say, well, if we had a population of 10,000 people, just at a minimum, and then applied those age-specific death rates from each country, what would the death rates be at that point? I'll show you a graph that kind of makes more sense of that in a second. But basically, that's going to be getting this standardized rate, and allow us to make a better comparison between the two groups. So let's look at the next group, or the next example here. So we're going to have two populations, let's say A and B, and they get divvied up into young, middle-aged, and older people. Okay, so that's how we're going to be breaking that down. And then we're looking at the age-specific death rate for each group, and we're actually going to see that for population B, it's actually twice as high as population A. When you're looking at the crude numbers, though, you're going to see that it doesn't really bear that out. It's going to look like Group A had much higher death rates from a crude perspective. But then when we actually standardize it to a single population, we're going to see how that will actually differ, and how that force of mortality looks a little bit more fair as a comparison between the two there. Okay. So do not get thrown off by the numbers. But here's some things I want you to kind of note here, right? So looking at this, we have population A, we have population B. Okay. Looking at their age groups, you have young, middle-aged, older, and then a total column here, total row. And so looking at the population size, you can see here that there's 1,000 people in the young group, 5,000 middle-aged, 4,000 in the older group. Population B, though, what do you notice about the age skew? It's a lot younger, right? So again, there's 4,000 people in the young group versus 1,000 in population A, right? Looking at the age-specific death rates for those, you can see here, 0.001 for the young group, all the way up to 0.1. And then versus here, you notice these are actually doubled, right? So these are just hypothetical numbers. When you actually look at a crude death rate, though, you look at this, say the total is 10,000, 451 divided by 10,000 is 4.51%, versus this group over here is 308 over 10,000, 3.81%. So if you were just looking at the crude numbers, you would say the death rate in which group is higher? Well, it's going to be in population A, right? Although we know the age-specific death rates are higher in population B, the crude numbers don't really bear that out. But let's say we were to go ahead and compare apples to apples. Let's say if we were to take those age-specific death rates and apply it to a standardized population where they all had the same proportions of young, middle-aged, and old. So instead we're looking at a total of 20,000, each group 5,000, 5,000, 10,000, 10,000, 5,000, and 5,000, right? So again, this is a sort of hypothetical population breakdown that we're being applying these same age-specific death rates to. And now when we look at it, we'll see what? Well, you have 605 hypothetical deaths out of that 20,000, so that's 3.03%, versus 1,210 deaths out of that 20,000, 6.05%. So by applying the standardized rate, what do we see? We can see the population B actually has a higher death rate. So even though that wasn't, you can actually see that here, even though if you looked at just the crude numbers, it does not really bear that out. But we're taking into account the fact that this population skews young, we can eliminate that, try to eliminate that confounder, that bias, and actually get apples to apples comparisons, okay? Now again, I'll give you one of these charts here, and you just have to fill in all the numbers and then get the person. I'm just kidding, you don't have to do that. But I want you to know the purposes of using an age-specific death rate and why that is very important when you're comparing two populations together, okay? You can also look at different cause-specific death rates. So again, you can make it specific for anything, right? So you can look at sex-specific, age-specific, anything you want to do. You can cause-specific death rates to make everything sort of to eliminate those confounders and try to eliminate as much bias as you can. But again, if you're looking at, say, cause-specific death rates, say you're looking at cases of MI between one country to another, also think about, well, how do the diagnostic styles change? What's the efficiency in healthcare, the access to healthcare between the different countries? How might that be influencing it? Because that can be another potential source of bias, right? So if you look here, countries with inadequate medical care, you may find 10 to 20% of deaths get signed out as symptoms, signs, and ill-defined conditions. It's basically like a shrug emoji, like, oh, they're just dead. We don't know why. Because they didn't have access to maybe a medical examiner who can actually go through and do a proper autopsy and find out why. So because of that, it can be very difficult to make those cause-specific sort of comparisons there. But again, the way you would do that would be exactly the same way as you do for an age-specific death rate. Again, the number of deaths due to a particular cause divided by that mid-period population of the people at risk for the event. And then you multiply by the constant multiplier. Same way we calculate things like age-specific death rates. Now, next up we're going to be looking at data on the leading cause of deaths for the U.S. between 1950 and 2000, as it was reported. And basically, we're taking this from information noted on the death certificates, right? So the physician who's signing it out basically said, what the death was caused by. And so you're going to find that the data, well, may not be super accurate for epidemiologic studies. It could be helpful for looking at kind of the different relative rates in the groups over time, right? We can kind of look for trends caused by that death over time. And basically, when looking at age-specific rates caused by cardiac disease and cerebrovascular disease, we're going to see that it's basically less than half of what it was, say, back in 1950, which makes sense because we have better treatment, better preventative medicine, things like that. Whereas we're going to see that certain rates for death of things remain pretty steady. So if you can look here, by using age-adjusted death rates between 1950 to 2000, you can kind of get a good idea for how things are evolving, how these trends are going to be going here. So cardiac disease went down pretty significantly. Neoplasms, what do you notice here? Relatively the same, right? So cancer rates have not really changed a whole lot during that time frame, right? Because again, are there a lot of like good preventative cancer measures? Not really, right? So how about things like unintentional injuries? That seems to have gone down for one reason or another. What about like diabetes? It increased a little bit, but so some things will go up, some things will go down, but this allows us to kind of make those comparisons. What about HIV? Well, we didn't even know about it back in the 50s, right? It wasn't a thing then. So sometimes you have brand new diseases that there's no comparator for, right? So anyway, so commonly used rates that reflect maternal and infant health. I don't know who these kids are, but they look cute, so I said. Now this is an old picture, but this is Lily and this is Phoebe. It's probably about a year ago. I need some better pictures. They look cute. Lily? Oh yeah, she has my temperament too. So, anyway, so I put them here because we're talking about infant mortality rate. So I wanted to kind of offset the dour subject with cute children. These were not statistics. They survived. They lived with us. But as you mentioned, we use infant mortality rates because it gives us an idea of like the overall health of a nation, right? It kind of tells us how well we're taking care of the babies, how well we're taking care of the moms, etc. Because obviously if moms are not being well taken care of, or if maybe they're abusing substances or have health conditions during pregnancy, they're probably not going to be giving birth to healthy babies, right? So again, that's another reason why we end up looking at this sort of stuff here. So anyway, so we can consider fetal deaths depending on when it actually occurs, and that can also give you information about kind of what were the potential causes around behind that. So for instance, like an early death would be something that would be like before the first 20 weeks of gestation, right? Versus say if it was a late demise of the fetus, such as like a stillbirth, that's 28 weeks or after, right? So they can give you different information depending on what are the common causes for those fetal demise during those time periods there, right? But for instance, like an infant death, when I say infant, what does that mean? It's first year of life, essentially, right? Versus if I say a neonatal death, yeah, it'd be like the first 28 days of life or so. So again, by looking at those different factors there, so for instance, a neonate might die for different reasons than say an infant would, okay? Because an infant's been alive for at least a little while, right? So presumably something during the care of that infant was the issue versus the neonate, they might have had something congenital at birth that really prevented them from making it past that time frame. So again, these are just different factors you're going to be looking at there. How about post-neonatal? What do you think that is? So past the 28 days, so 29 days up to a year essentially, right, is another way we can look at that. And so again, you can get crude birth rates and just look at that. Again, this would be similar to where you have number of live births divided by that mid-period population, right? So again, looking at, now again, would I use the entire U.S. population here? No, why not? Because, right, there's not a lot of Mr. Moms out there, right? When you have birth. Was that a Arnold Schwarzenegger movie? Perhaps. Anyway, so you got to look at, be specific, all right, people of childbearing potential, how they define that can be important depending on the study you're looking at, and again, they still multiplying by that factor there. And so looking at some of the rates we can look at, so for instance, health of the infants is usually sensitive to maternal health practices. So again, do you have a lot of moms who maybe are abusing tobacco, alcohol, they're getting good nutrition during their care there. Using the infant mortality rate is oftentimes indicative of that, right? So again, how well are the women taking care of themselves, thus how healthy other babies are when they're coming out. And so other things we can use here, the added advantages is that most countries do report their infant mortality rates, right? So you can kind of compare it between everywhere. And then also being age specific is pretty easy, right? Because what's the age of a neonate? It's always that first 28 days, excuse me. So because of that, you don't have to really worry about like, were they really old neonates we're dealing with or really young? It doesn't really have that much of a factor there, right? Because they're just neonates. And so again, the numerator, denominator typically gets reported to these kind of vital statistics systems. And again, looking at this, you can kind of tell how you actually get infant mortality rates. Well, anyone less than a year that dies during that time period divided by the number of live births. So again, why does that number seem valid? Was it they died earlier, then that doesn't really tell you much, right? It wouldn't be counted in that number there. So again, people who actually survived during a certain time period, that live birth period, that's going to be your denominator in those cases there. You could potentially use number of pregnancies, but why would that be incorrect? Yeah, not all those pregnancies were carried to term, and so in that case, that would be an invalid denominator. Sometimes you'll see it used as a surrogate, so to speak, in order to, if they don't have the actual numbers of live births available, they may use number of pregnancies, but again, there's some limitations to that. And again, just knowing that the neonatal mortality rate is usually a reflection of the medical services and of the maternal prenatal behavior, right? So again, how good was the hospital services after the kid was born, also how well is the mom taking care of themselves, versus that post-neonatal period is usually a reflection of the home environment, right? So again, was the kid getting adequate nutrition? Were they placed in a position where they maybe were able to injure themselves? A lot of different reasons for that, but they tell you different things essentially, depending on where the death actually occurred. And so other things we look at, pregnancy, we consider this sort of a normal biologic process. And even though the pregnancy we know can put considerable strain on the female, right? And so not every mom is going to necessarily survive pregnancy. And so we can also look at these things here to tell us some information. So we can look at maternal mortality rate as also indicative of, again, how well we're taking care of these patients here. And so we look at the number of pregnancy-related deaths divided by the number of live births. Does this make sense? Right, we think. So again, this is looking specifically at that period there where mom dies as a complication of the birth itself, and that makes sense if you had the live birth, but the mom died during that, that would make some sense there. So again, there's different ways we can calculate these, but this is kind of the most common way that would come up. And so, as I mentioned, the equation is based off the number of pregnancy-related or the puerperal deaths that occurred during that time frame. So again, so it could include even several days to weeks afterwards if the mom died from a complication of the actual labor itself. Because again, it's not necessarily related to things like an automobile accident or homicide, but you include basically things that are related to the complications there of that labor. Okay, and you mentioned the denominator in that point there should be the live births. But you may find, for simplicity's sake, they may use the live births as an estimate of the total number of pregnancies. Because again, the number of people who get pregnant throughout the year may not be reported, but certainly live births will be more commonly done so. So usually we're going to see the constant multipliers by 100,000. What do you think that is? How often do we have infant mortality? Is it a relatively rare occurrence or a very common occurrence? Pretty rare for the most part, right? You all survived, right? So it's fairly rare, and so because of that, if we even did it per 10,000 live births, the numbers would still be like 0.2 something per 1,000 live births, right? So it doesn't really make good logical sense there. So we use per 100,000, so that way we at least get to some kind of whole numbers. That makes more intuitive sense to people. Because again, it went from, in 2001, the maternal mortality rate specifically went from 8.2 or was 8.2 per 100,000, it would make really sense to say 0.82 deaths per 10,000 live births, right? Because you can't have 82% of a mom die, the rest of it survived, right? It just doesn't work that way. But anyway, however, you saw that you can even do this per different subsets of the population. So for instance, you're looking at the rate for white patients is around 6.2 versus say for Black Americans, the rate was 20.1. Right, so already you can start to see some different effects of maybe socioeconomic status. You can see different factors in terms of access to care, prenatal care, things like that. You can start to dig in to see why these numbers are so different to get some better information about that sort of thing. So those are rates. Those are ways you can calculate risk and getting specific rates and risk and things like that. Any questions on this section? All right, so make more sense we do some of the journal clubs, and we're going to start to look at more epidemiologic-based studies. And I think our next meeting is going to be a journal club. Is that correct? Anyone know? I think next week or something we're going to do that. I think we may have an 8 o'clock session or a 10 o'clock session perhaps. We'll look at it and see. But I don't see any questions, so I will see you guys next time.